Hello, my name is Tiffany Almeida, Training Director of the Old Dominion EMS Alliance, and welcome to this special presentation. In August 2020, our office was contacted by a friend of Mr. Jerry Crean, a man living with ALS in the ODEMSA region. Mr. Crean had one simple request, but he needed a little help. His mission? To bring awareness to our region's EMS providers regarding the care and needs of patients with amyotrophic lateral sclerosis, also known as ALS. His desire to spread his message directly to EMS providers came from personal experience. Upon speaking with fellow ALS patients, Mr. Crehan realized he was not alone. Shortly after Mr. Crehan's diagnosis, he decided he would dedicate his life to revealing the difficulties ALS patients face, including when accessing the 911 system. In the following interviews, you will hear from Jerry Crean in his own words and from his physician, Dr. Kelly Gwathmey of VCU Health. This video will provide introductory education regarding ALS. Furthermore, we hope to fulfill Mr. Crean's mission by providing EMS providers with helpful insight and clearer understanding into the needs of ALS patients should you be called to a person with ALS.
Hello, my name is Jerry Crean. I'm 68 years old. I'm a retired businessman, been here in Chesterfield County for a little over 38 years. And before I begin telling you my story, the first thing I want to say to you all is thank you very much from the bottom of my heart for all that you do. I've had need of emergency medical services several times in the course of my life, and you're all awesome people. I wish I could hang out with you, and if you ever want to hang out with me, I have the beverage of your choice here, so come on over. Now, my story. 4 years ago, I was on vacation, jumped off the back of my pickup truck, landed hard on the ground and thought, ouch. Thought I hurt my feet pretty badly. Through the course of the year, I kept trying to see the doctor, and he kept trying to tell me that, Jerry, you're just fat and lazy. Go work out. Well, you know, I was working out. Every day for years and years I was working out, but I found I was still having difficulty walking up a set of stairs. Just burning sensation. Finally, my PCP agreed to send me to an orthopedic doctor. He took one look at my feet, said, yeah, you have a problem here, but I could fix that in a few days. As to the other issues, I want you to go see a neurologist. And, well, I know a fellow whose son is a neurologist. I thought, well, maybe with his hookup I could get in to see him quick. Still took 6 weeks to get in to see him. And of course, the first thing they do is send you off for a bunch of tests, right? I went and had a bunch of tests, and on January 6th of 2017, he told me that I had ALS, or as we call it, Lou Gehrig's disease. He said, but I hope I'm wrong. Sent me off to a university setting where he wanted to get a second opinion. So I went down to the Virginia Commonwealth University's Medical College of Virginia campus and had a second opinion. And the diagnosis was confirmed then. So almost 4 years ago, I was told that I have Lou Gehrig's disease. And I have to tell you that that's a devastating blow to hear. You kind of go into a little bit of a fog, if you will. You just don't know what to do or what to think. And in fact, that very day, I was to deliver a eulogy to my best friend's funeral. And it was just like I didn't know what to do. So, at the clinic, I met a multidisciplinary team One person after another came into the exam room. Respiratory therapy, physical therapy, occupational therapy, social work. I saw a chaplain. I saw workers from the Muscular Dystrophy Association, the ALS Association, all to learn a little bit about what ALS is. And while I'm not a medical expert, not here to tell you or train anyone in disease processes, just let it be said that it's a neuromuscular disease where the neurons fail to communicate with the muscle, and then the muscles begin to atrophy and die out. And as you can see me now in this chair, I can't really move anything except my neck a little bit and 2 fingers on either hand. Everything else is now gone. So I'm now 4 years into what they say is a 2 to 5 year diagnosis. What will end up getting me in the end is the inability for my diaphragm to contract and relax and allow me to breathe on my own. So one of the first things that they do, and they did with me way back in January 2017, was to put me on this machine that we call Trilogy. Trilogy is a non-invasive ventilator. This past year, we've heard a lot about non-invasive ventilators with the pandemic coming around the world, and our government trying to manufacture more and more of these things. But I have one of them that I wear pretty much 24/7 nowadays. So it helps me to breathe. And I get short of breath even with this conversation that I'm having with you now. I'm getting short of breath. My desire to speak with you today was born out of a couple of incidents that I endured. The first one was last February, when my wife was out of town at a speaking engagement. She was actually flying back from Los Angeles when a co-worker of hers, a nurse, was here watching me, and I had aspirated on, believe it or not, a drop of water. I just started choking on a drop of water. I just couldn't have enough breath to clear my throat of that, and I coughed for, I think it was 6 straight hours. I was coughing. And the nurse who was here with me just got to a point where he said, "This isn't good. We're calling 911. So he did. The squad was here, seemed like almost instantly. Thank you very much. Here instantly, the first thing they did, of course, is pull out all their equipment and put an O2 sensor on my finger, and saw that my O2 sats were down to 88%. So they ripped the mask off of me and put a nasal cannula on and started pumping me full of oxygen, which might have seemed like a good thing to do, but I wasn't able to expand my lungs. But my lung capacity at that time, at last February, was still sufficient that it didn't cause any other serious arresting conditions. I just struggled through it. They transported me to the hospital, where there I was put on a non-invasive ventilator. Again, and given some treatments and spent a couple of days in ICU, the follow-up from all of that activity. Well, fast forward then several months, my wife had just got me up from a nap, put me in my chair, and while I was in our master bedroom, she asked if I wouldn't mind staying there because she had some things to do out here in this room. And I said, that's fine. I had some phone calls to make. So I did not have the ventilator on at the time. I made my phone calls, But she had commented to me earlier in the day that there were some really pretty flowers out my side window. So I wheeled my chair over to the side window. At that point, I was using a joystick to control my chair. So I had to raise my chair higher, tilt it forward so I could look out the window to see downward at these pretty flowers. They were really pretty. But the consequence of me tilting my chair threw my hands forward off of the controls. Now I can't control the chair at all because I can't move back to the controls. I was not wearing this chest strap that you see on me, which incidentally I now call my bra. It just holds up things. Okay, anyway, so I was not wearing a chest strap, and I fell forward. My forehead banged up against the window. I had about 4 or 5 breaths before I totally blacked out. I don't know how much longer it was later when Sue, my wife, came back into the room, found me unresponsive. My complexion was blue. I wasn't breathing. She could not find a pulse. She's certified in CPR and began to do chest compressions. She called the squad, and again, the 911 operator counted with her through the whole process, but told her that it was going to be like 8 minutes before the squad got here. So at 100 compressions an hour, or a minute rather, 100 compressions a minute, she was beating me up. By the time the squad got here, they put the machines on and found me to be normal sinus rhythm. But one of the first things she did was to put the ventilator back on me, because this ventilator will actually breathe for me. So while she was doing chest compressions, the ventilator was helping me get oxygen back into my system. So ALS is a disease where you lose your muscularity, you lose all of the ability to move eventually. Each and every one of us is different. Some of us, it starts at our feet, as it did with me. Some starts at the head, some starts with the neck, some starts with your ability to swallow and to speak. So every one of us is different. But in the end, what happens is you're just not able to breathe anymore. And so an ALS patient, among God knows how many other disease processes there are, it's really, really, really important for us to be able to breathe. And through the course of having support group meetings with other, we call ourselves pals, patients with ALS, with other pals, we've heard of stories where a life-ending experience happened because a patient was without their ventilator, either in an emergency waiting room or waiting for EMS, or the fact that in the ambulance itself they weren't afforded the opportunity to bring their machine. I'm not here to legislate or anything. I'm just here to say that as an ALS patient, I can't live without this machine. It's even hard to talk without it. So that's my story, and I hope and pray that this message can get out to everyone. I just hope that seeing a real patient not being able to move a muscle in their body and hardly able to breathe would be an inspiration and a confirmation of how much we need to have the equipment we're here. Living with this thing for 3 years or so, I can understand someone walking through the door and saying, I don't know how to work that machine. Well, I do. My wife does. We know the machine. We know how it works. It's set up. You don't need to actually even touch it. The batteries will work for 6 hours. That's plenty of time to get to a hospital. Those people, like I said at the outset, God bless each and every one of them. I think they're the most awesome people in the world. To run into a fire, to run into an accident scene, to run into a house, not knowing what you're going to find. They are heroes every single day. God bless each and every one of you.
With ALS. Dr. Gwathmey, thank you for joining us today. If you could, take a moment and tell us a little bit about yourself.
Thank you so much for having me, Tiffany. Yes, I'm Kelly Gwathmey. I am a neurologist that specializes in neuromuscular disorders. Those are disorders of the peripheral nervous system. So I actually don't take care of any brain or spinal cord problems. And so within that umbrella of disorders that I manage is ALS, or Lou Gehrig's disease. And so I originally from Richmond, and I grew up here, went to college at Emory University in Atlanta, and then went to medical school actually in Norfolk at Eastern Virginia Med School, where I met my husband. We couples matched to UVA, where we completed our residencies. I did a clinical neurophys fellowship there, then a neuromuscular medicine fellowship in Boston at Mass General and Brigham and Women's, and then went back to UVA in 2013, where I was on faculty for about 6 years before being recruited to VCU about 18 months or so ago. And here I help to take care of the amazing ALS patients, in addition to seeing other neuromuscular patients in the Richmond area.
In the EMS world, ALS is more commonly referred to as advanced life support. Can you tell us what is ALS in your profession?
So ALS, or Amyotrophic Lateral Sclerosis, is otherwise known as Lou Gehrig's disease. So many patients are more familiar with that term instead of ALS. And it is a neurodegenerative condition that causes painless progressive muscle weakness. So we will see that patients start to have weakness typically about 60% or so of the time in a limb first. So it might be right foot weakness or left hand weakness. And over time it spreads to other regions of the body. About 30 to 40% will start with some weakness of their throat muscles, which will translate to weakness of swallowing, speaking, and sometimes even breathing. And as the disease progresses, most patients develop difficulty speaking, swallowing, and breathing. And unfortunately, they ultimately pass away from the breathing difficulty or from an aspiration pneumonia related to the swallowing difficulty.
What is involved in the process of being diagnosed with ALS?
Well, it's sometimes not very speedy, to be honest with you. A lot of patients will go to several different providers before they ultimately come to us for a second opinion or with the diagnosis. Because it starts so focally, for example, someone might just have hand weakness or foot drop. And so patients might go see a hand surgeon and they think that they have carpal tunnel syndrome, for example. And so they end up seeing a provider and then ultimately get routed to neurology. And so as the disease progresses and spreads, it becomes more obvious what the diagnosis is. And so the diagnosis really hinges on a combination of symptoms and signs on exam. So a mixture of weakness, of course, of the muscles, jumpy reflexes, muscle atrophy, and twitching or fasciculations on exam. Now, all patients end up having an EMG or electromyography to support the diagnosis, but that by no means is the end-all be-all test. It really is the exam.
What is the typical life expectancy of someone diagnosed with ALS, and does it vary?
It can vary, and we see patients on all ends of the spectrum, absolutely. There's some patients that we follow for over decades with more benign variants of the disease, and some patients, unfortunately, have a very precipitous course and will decline in under a year and pass away. But like I said, the average is more in that 2 to 5 year range.
What are the typical signs and symptoms that ALS patients have?
Sure. So, as you can imagine, the problems that they have are tied to where their weakness is. So for patients who have symptom onset in their legs and progressive weakness in their legs, they have difficulty walking. And so they'll rely on a number of different assistive devices, be it a cane to a rollator or walker. And then most patients eventually end up in a power wheelchair to help with their mobility. So symptom onset in the hands or arms, that affects their activities of daily living. They can't dress themselves, feed themselves, things along those lines. And then as patients have involvement of their bulbar muscles, they have the changes in their speech. A lot of patients actually end up not being able to speak or communicate by speaking, and so they have to use different types of technology to communicate with their caregivers and their loved ones. And then also with the swallowing, a lot of patients lose their ability to swallow completely, and they might rely on a feeding tube to get their nutrition. Also, when patients develop difficulty with breathing, they may rely on non-invasive ventilation, like a Trilogy device, which is like a fancier BiPAP, is what we're using these days. And a lot of times patients will start to use that at night. And then over time, as the disease progresses, they have to rely on it more during the daytime as well.
You mentioned the Trilogy BiPAP device ALS patients commonly use. Would a CPAP device our regional EMS providers carry be a viable alternative to not transporting the patient's Trilogy machine?
Sure, and I'm certainly not a pulmonologist, but the bottom line is that the non-invasive ventilators that we use to support our patient population have a lot more bells and whistles and support, and so they have more settings, and so they really do function as non-invasive ventilators as opposed to a CPAP machine, which doesn't just provide the same degree of support and pressure that our patients need. When I was coming through residency and early in my career, everyone was on BiPAPs, and now we've gone to this like tri-level thing. So again, I have limited knowledge of the inner workings of this equipment, of course, but it's pretty astonishing what we're able to do and how it translates to improved life expectancy when we can support them from a respiratory standpoint.
What is the prevalence and incidence of ALS in the general population?
It's probably about 4 per 100,000 is the prevalence. The incidence is like 1.5 to 2.5 per 100,000. So it's considered a rare disease, though there seems to be a lot of patients that we care for in the Richmond area. We keep about 100 to 130 active patients in our clinic at any given time.
Are there specific groups that are more at risk of developing ALS?
Our veterans, for some reason, we don't know exactly why, but seem to be at higher risk of developing ALS. And so that is, in a way, a silver lining if you get this diagnosis and you're a veteran, because the VA is very good about providing a lot of support to these patients through medications and equipment and multidisciplinary care on that side as well. Also, other risk factors. So about 10% of ALS is familial or genetic. So there's a family history, or if we were to do genetic testing, we would find an abnormal gene mutation associated with it. Still 90% is sporadic, and it seems to be more concentrated overall in sort of the middle ages. So age 40 to 60 seems to be the most common time that patients are diagnosed. It's weighted slightly more towards men than women. And those are most of the things. There's some work being done in environmental kind of risk factors and exposures as sort of lowering the threshold to developing this. So that'll be interesting to follow over time, that work.
How are ALS patients managed, and what treatments may they require?
So I give this talk to our patients every single week. There are a lot of different ways we can think about how we manage the ALS patient. First and foremost, most of our patients are followed in a multidisciplinary care setting. And so at VCU, we have our clinic every single week on a Tuesday and see tons of patients. And so what's multidisciplinary care? We have physical therapy, occupational therapy, speech therapy, respiratory therapy, a dietitian, a genetic counselor, nurse coordinators, social workers, ALS Association representatives, and so on, vendors as well. And so it really does take a village to care for these patients because they have so many needs throughout the course of their disease. And so that's one piece of it. We know that being followed in that care setting results in improved quality of life as well as life expectancy. Then the other kind of bucket that we think about is in terms of treatment is medication. There are 2 FDA-approved medications that slow the progression of the disease. And I won't go into too much detail there, but one is a pill that's been around for 25 years called Riluzole, and the other is a newer infusion therapy called Radicava. And then the third bucket that we think about is symptomatic management. So how do we support these patients throughout the course of their disease? So from a kind of medication standpoint, these patients will get cramps, so we manage that. They'll have increased secretions, drooling, constipation, emotional concerns or mood concerns, of course. We manage all of that with medications. Of course, equipment too. So that's why we have all of our therapists in clinic, is to help us get the power wheelchairs taken care of, and also to take care of the non-invasive ventilators that we order and manage as well.
You mentioned progressive muscle weakness. Can ALS patients feel touch?
Absolutely. This is a pure motor disease, and so their sensation is completely intact. So they can feel pain, absolutely, or if someone touches them, they can feel that. I think in general, the very important thing to remember about this disease is that even though patients lose their ability to move their arms and move their legs and talk and swallow, they're still in there, right? So their brains are still working well. They understand what's going on. And so if you see a patient with ALS, you might not realize that initially because they can't communicate with you, but they absolutely understand what's going on.
What are some common reasons an ALS patient may need to seek urgent medical care or be hospitalized?
I think in general, we do a pretty good job of keeping people out of the hospital because we touch base with them so frequently and assess them ourselves if something is happening. That said, the most common things that we see occur are aspiration pneumonias, really. So patients will develop fevers, chills, worsening shortness of breath, and that is an emergency. Because our patients almost universally aspirate at some point during their disease, this is a common occurrence. And so a lot of our patients, if they end up in the hospital, it's related to that. The other reason that our patients get hospitalized is if they take a fall, they're having progressive muscle weakness, perhaps they're not yet in a powered chair, manual chair, and they take a fall and they break a bone. So sadly, sometimes they end up hospitalized with a broken bone as well. But those are really the two things. Sometimes the patients who receive the infusion therapy, they have almost like a chemo poured in. They have a permanent line. Sometimes they get infections in that too. And so we've had some patients that have developed blood infection, sepsis because of that.
Does ALS fall under any larger spectrum of disease, or is it related to others such as Parkinson's or multiple sclerosis?
So ALS, very interestingly, overlaps with frontotemporal dementia. So even though we all the time preach that these patients have intact thinking and memory and all those good things, there is a small fraction, probably about 15% of patients that develop concomitant difficulty thinking. And it's a very specific type of dementia called frontotemporal dementia, which is different than Alzheimer's. And we see it very prevalent in the genetic forms of ALS. They also feel that about 30% of patients will have some mild cognitive impairment or behavioral change associated with the disease. But ALS itself, it's a neurodegenerative disease, so you would think about it in the same categories as Parkinson's disease or Alzheimer's, like the nerve cells themselves start to die for no reason whatsoever. It's almost like getting struck by lightning. So that's very different than our autoimmune or immune system directed diseases or immune system dysfunction related diseases such as multiple sclerosis or other things along those lines, where you actually can treat the underlying cause of the disease and the patient will improve or stabilize.
Do ALS patients have issues with body temperature regulation, like we see with spinal cord injury patients?
The autonomic nervous system, which allows us to regulate temperature and heart rate and blood pressure and all those good things, is spared in this disease. And so they should have normal bowel and bladder function, normal temperature regulation, all of that. Now, patients all the time will state that they're cold in their feet because they're not moving around very much, but that's a little bit different than what you're asking, yeah.
Speaking of GI-GU processes, what would the EMS provider see in the field with ALS patients regarding daily GI-GU routine?
For the men, yes, they have a condom catheter a lot of times just because it's significantly easier. There is a female equivalent external catheter on the market that these patients would have to pay for out of pocket. Insurance doesn't cover it. And so that we don't see that utilized very much. But otherwise, we don't use indwelling catheters just because of the risk of infection. And we don't do in and out catheterization typically. So someone will have to help transfer the patient out of the power wheelchair, if that's where they typically stay, onto the commode. We use a lot of bedside commodes and that sort of thing to help ease the bathroom situation. Yeah.
With ALS patients being unable to move in later stages of the disease, do we see more instances of DVT or PE in this patient population?
We, interestingly, don't see very many DVTs, blood clots in this patient population, which is one of the great mysteries of the disease. Why is that? They're immobile. Similarly, we don't see that much in the way of skin breakdown in these patients. Also very interesting because they're immobile and they're often in bed towards the later stages of their disease. Yeah, so in theory it can occur, we just don't see it that often. I can, count on one hand the number of patients I've had a DVT or a PE on my watch, so, yeah.
It appears EMS is likely to come across a caregiver when responding to an ALS patient. Is this correct?
The vast majority of these patients live with someone else who provides care to them, often around the clock towards the later stages of the disease. So that's often a loved one or a spouse. Sometimes there are nurses that come into the home to help to care for these patients. Some of these patients, just a few, are actually permanently trached and vented. And so that's a completely different situation when you come into a patient's house, and they often will have a nurse or a caregiver around the clock because they require a lot of suctioning and ventilator care. So there's less than 5 of our patients that are permanently ventilated, but that is an occurrence you will sometimes encounter. And those patients do sometimes get aspiration pneumonias as well, or mucus plugging, and they often will have to go into the hospital following something like that. Yeah.
What do you feel are the most important things for our EMS providers to keep in mind when caring for ALS patients?
So the disease, again, it's a spectrum, right? So there might be a patient you walk by on the street that you would never in a million years know has ALS because they're in the very early stages, all the way up to the patient who's unable to speak, unable to breathe on their own, and unable to move their arms and legs. And so that really is the spectrum of the disease. Just remember that these patients are very much awake and alive inside, even if they can't communicate with you. And also understand that our patients who are on these non-invasive ventilators, these Trilogy machines, they need them to survive, right? They are very dependent on them. Many of them would decompensate so quickly if we took them off of their machines. And so towards the later stages, that is really the way that we continue to support them in the best way possible. So those are the take-home points.
Thank you for your time, Dr. Gwathmey. We appreciate it.
Absolutely. Thank you.
Absolutely. You have just heard from Jerry Crean and Dr. Gwathmey. When responding to a call for service to an ALS patient, remember a few things. ALS is a progressive condition that affects the muscles. Recall, the diaphragm is also a muscle, and its function will eventually deteriorate in ALS. Thereby, when caring for an ALS patient, it is essential EMS providers pay close attention to the ALS patient's ventilatory status and needs. Depending on where the ALS patient is in the progression of their condition, the patient may or may not need ventilatory assistance. If the ALS patient does require day-to-day ventilatory assistance, it is often by way of non-invasive BiPAP machines, such as the Trilogy, a commonly used device among the ALS patient population. As you saw with Jerry Crean, not all ALS patients are trached. Some use the device through the nasal route, like Jerry. Some ALS patients use their device full-time, and some use it as needed. For example, when we met Jerry, he was not on his non-invasive BiPAP machine. However, as time went on, Jerry became tired by talking and eventually was placed on his machine. Either way, understand the ALS patient's non-invasive device plays a vital role in their life and an integral part of their care. These non-invasive ventilatory machines are adapted strictly for each ALS patient's unique ventilatory needs. Whether or not the ALS patient uses the machine full-time, Jerry Crean would like you to know, please take the device with you to the hospital. In terms of the continuum of care, respiratory staff at the hospital can use the settings from the patient's device to meet the patient's needs. Additionally, bringing the patient's device with you to the hospital will help lessen anxiety and provide greater comfort to the patient knowing their device is with them. And above all, if you have questions, we encourage you to reach out to medical control or your agency's medical director. The Old Dominion EMS Alliance is honored to have been a part of this project. We thank Jerry Crean for sharing his story, Dr. Gwathmey for taking time with us, and thank you for joining.